day. My name is Biodun Nesin Olagbije. You are welcome to this section. In this section, we will be considering prolonged pregnancy and postpartum pregnancy. At the end of this section, I expect you to understand the definitions of prolonged pregnancy as well as its epidemiology, etiology and risk factors, pathogenesis, complications, as well as and also its management. Okay. The duration, we know that the duration of gestation is between 280 days and 290 days from the first day of the last menstrual cycle in a woman with a 28-day regular cycle. This corresponds to 40 weeks through 41 weeks and 3 days. Prolonged pregnancy is defined conventionally and arbitrarily as pregnancy after 41 weeks of gestation. This definition has been considered to be ill-defined and is being advised to be avoided. Postpartum pregnancy refers to pregnancy that has extended to or reached for 2 weeks of gestation or the expected day of delivery extended beyond 14 days. Late-term pregnancy refers to pregnancy between 41 weeks and 6 days gestation. Among all pregnancy, the incidence of prolonged pregnancy is approximately 7%, and the prevalence varies it depends on population characteristics and local management practices. With respect to population characteristics, the following factors influence the prevalence of prolonged pregnancy. This include percentage of primigravidas in the population, the prevalence of obesity, and prior postpartum pregnancy, as well as genetic predisposition. The local management practices that influence the prevalence of prolonged pregnancy include the rate of scheduled induction of labor in the population, as well as differences in ultrasound dating of pregnancy. It's been found that accurate dating of pregnancy in the first trimester has resulted in a drop in the prevalence of prolonged pregnancy from 12% to 3%. Elective cesarean section rates have also been found to influence the prevalence of prolonged pregnancy in the population. As I said, the etiology and risk factors of prolonged pregnancy are displayed on the screen. Inaccurate dating is the most commonest cause of pregnancies being prolonged or being postpartum. Among pregnancies that are truly prolonged pregnancy or postpartum pregnancy, unknown, the cause is unknown. Other factors that have been associated with prolonged pregnancy include previous postpartum pregnancy. It's been found that among women with one previous postpartum pregnancy, the prevalence of prolonged pregnancy is about 27%, while approximately 2/5 of women with 2 previous postpartum pregnancy develop postpartum pregnancy in the current pregnancy. Obesity has also been found to be associated with prolonged pregnancy or postpartum pregnancy. Obesity is the only modifiable factors associated with prolonged pregnancy. The causal link between obesity and prolonged pregnancy remains not clearly understood. It's been related to hormonal factors. Genetic predisposition has also been reported to influence the prevalence of prolonged pregnancy. There are reports that women who were products of prolonged pregnancy or twin gestation are at higher risk of developing prolonged pregnancy in their current pregnancies. Male factors, the male fetus is also a significant risk factor for prolonged pregnancy. Hormonal factors have also been implicated as a risk factor. Has also been indicated in the etiology of prolonged pregnancy. For instance, placenta sulfatase deficiency has been documented to be related to the incidence of prolonged pregnancy. The pathogenesis of prolonged pregnancy or postpartum pregnancy is not clearly understood. There's a lack of clarity about the exact mechanisms initiating labor. It's been documented that understanding the pathophysiology of parturition will shed more light on the pathogenesis of these conditions. The mechanisms of parturition include hormonal, mechanical, and inflammatory processes, and this corresponds to placenta fetus, and the placenta fetus and mother each plays a role. The placenta production of peptide corticotrophin releasing hormone has been related to the length of gestation. In women with premature delivery, there has been documented reports of exponential rise in the placenta corticotrophin hormone, while slower rise in placenta corticotrophin releasing hormone has been reported among women with postpartum pregnancy. Placenta corticotrophin releasing hormone stimulates the fetal adrenal production of dihydroepiandrosterone, which is a precursor of the placenta estriol. And rising level of estriol and estradiol ratio has been found to provide a favorable estrogenic environment in the last week of pregnancy, thus leading to labor and delivery. Significant complications have been associated with prolonged pregnancy or postpartum pregnancy, and these complications include fetal and neonatal morbidity and mortality. Perinatal mortality rate in term pregnancies range from 2 to 3 per 1,000 deliveries. At 42 weeks gestation, the perinatal mortality rate of 4 to 7 per 1,000 deliveries have been reported. At 43 weeks gestation, the risk of perinatal mortality increased to 4-fold compared to the risk at 10, while the risk of perinatal mortality at 44 weeks of gestation increased to 5 to 7-fold compared to compared to 10 pregnancies. The causes of perinatal mortality include uteroplacental insufficiency, meconium aspiration, and intrauterine infection. Fetal morbidity associated with prolonged or post-term pregnancy include the passage of meconium aspiration syndrome, fetal macrosomia, and dysmaturity syndrome. Neonatal morbidity that have been associated with prolonged pregnancy in the literature include neonatal acidemia, low 5-minute APGAR score, fetal macrosomia. Fetal macrosomia has been associated with prolonged labor, cephalopelvic disproportion, shoulder dystocia, and risk of cesarean delivery. Neonatal encephalopathy has also been reported to be associated with prolonged or post-term pregnancy. The maternal risk associated with prolonged pregnancy include labor dystocia, 3rd and 4th degree perineal tear, operative vaginal delivery, increased cesarean section rates, and emotional impact. It's been reported that there's an increased risk of having labor dystocia in women with prolonged or post-term pregnancy compared with women with term pregnancy. It's also been reported that women with prolonged or post-term pregnancy in labor are at higher risk of developing third and fourth degree perineal laceration. This has been related to fetal macrosomia. Cesarean section rates double. The cesarean section rates double in women with prolonged or post-term pregnancy compared to women delivered at term. Okay. The management of prolonged or post-term pregnancy includes pregnancy dating, antepartum fetal surveillance, prevention, and induction of labor. Accurate dating of pregnancy is essential for the diagnosis and management of prolonged pregnancy. It's been found that the rate of prolonged pregnancy decreases from 10 to 15% to about 2 to 5% with accurate dating of pregnancy. We need to understand that ultrasound has margin of errors. In the up to 27 weeks of pregnancy, the margin of error related to the pregnancy dating is about 7 days. In between 20 to 30 weeks of pregnancy, the margin of error is approximately 14 days and is about 21 days in pregnancies that are 30 weeks and above. There is no evidence to suggest antenatal fetal surveillance decreases perinatal mortality among prolonged or post-date pregnancies. However, the common practice is to do antenatal fetal surveillance. This is based on universal acceptance and is not based on strong evidence. The antenatal fetal examinations that are useful for monitoring prolonged and post-term pregnancy include counting fetal movements, computerized visual or computerized fetal heart rate, osteocin test, ultrasound test for oligohydramnios, Doppler indices, and biophysical profile score. I want to say that the evidence supporting the benefits of this monitoring test is not strong. Induction of labor is indicated in prolonged or post-term pregnancies when the benefits of delivery outweigh the associated risk. There are concerns around induction of labor. These include uterine overstimulation, fetal distress, failure of induction of labor and subsequent cesarean section, as well as uterine rupture. Commonly, induction of labor is performed between 41 weeks and 0 day and 41 weeks and 3 days. How should delivery be induced? For women with prolonged or post-term pregnancies, labor can be induced by stripping the membranes. Induction of labor with osteocin. This is usually performed for women with a ripe cervix at 41 weeks and later. Other pharmacological agents that can be used for induction of labor include prostaglandin E1 and E2. These two pharmacological agents can be used regardless of cervical ripeness. Prevention of post-term pregnancy seems to be the best management, and the methods identified in the literature include membrane stripping, unprotected sexual intercourse, nipple stimulation, and acupuncture. In conclusion, Postpartum pregnancy is associated with significant fetal, neonatal, and maternal morbidity and mortality. It is important to note that 42 weeks gestational age does not represent a threshold under which the risk of fetal, neonatal, maternal morbidity and mortality are uniformly distributed, and there's evidence of increased risk of fetal, maternal, neonatal morbidity and mortality before 42 weeks of gestation. In light of current evidence, earlier intervention at 41 weeks gestation is recommended. Thank you for listening.